Good afternoon, doctor. We are very excited to have you here in the Dentist Channel Online green room. Would you like to introduce yourself and your practice?
Hello everyone, my name is Dr. Ashish Sethi. I am a cortical implantology and I did my masters from Switzerland in the immediate loading implantology. Nowadays I am practicing in Chandigarh under International Implant Master, which is my clinic name, which is a clinic as well as academy for the person or the dentist who actually want to learn the advancements in the cortical implantology. We have centers in Delhi, Ghaziabad as well as in Rajasthan.
Doctor, so which area of implantology interests you the most?
I'm doing in the field of implantology since 2009. When I started my practice. But during the phase when I was doing the implants, I feel lots of problem while doing the conventional implants, which actually make me to shift from the conventional implantology to the cortical implantology. So I did my conventional implant practice for the 10 to 11 years. Later on I learned the cortical implants, and nowadays I'm doing exclusively the cortical implants and do all the challenges, accept all the challenges and every cases what are rejected by the conventional implantologists. Now I'm doing all these cases nowadays.
So could you explain further about cortical implantology and its application?
Yeah, definitely. The cortical implantology, when I started the cortical implants, as you can see, implants is basically not only for the person who actually who have a missing teeth, but it is for the every person who have a failed endodontic treatment, who did the orthodontic extractions, who undergo like prosthetic replacements, everything. But when I start my implant practice at that time, it is very easy to replace a single tooth replacement or a multiple tooth replacement or a full mouth if the bone condition is good. But there are many conditions when the bone conditions are not good. In such cases, what happens actually, we used to be prepare for the sinus lift surgery, we used to prepare for the nerve repositioning surgery, and we used to prepare for the many other complicated procedure what we can go with that. But what happens being a general practitioner or being a regular dentist, so what happens, we are not used to do such cases. We are not able to do such complicated surgery. It's not possible or not a cup of tea for every dentist. So what happens, normally either the patient say no to the dentist or the dentist say no to the patient, because this is quite complicated. If the dentist say yes to the patient, yes, I can go for that. So what happens, there is a very hefty amount the patient has to pay. Moreover, the patient have to undergo very multiple complicated surgeries. So that actually a problem for the patient as well as for the dentist. So these are the many dental challenges the patient usually have as well as the dentist have. As far as we concern about the dentist may have the complication or the problems like the peri-implantitis after the implant placement, or if the patient is a diabetic and the HbA1c level is above 7. We used to say, patient, please lower down your diabetic or reduce your HbA1c, then only we can go for the treatment, because it becomes very difficult for us to treat or to such patient if the bone condition is not good and the healing is not proper, then it may be difficult for the patient as well as for the doctor. Or if the patient is a heavy smoker, we also used to say no to the patient, because the smoking itself reduces the alveolar bone, that may lead to failure of implant. Or we need lots of armamentarium in many cases. In cases of the conventional implantology, if the patient have a poor oral hygiene, or the main thing is osseointegration, because once we have placed the implants, we need at least 3 to 4 months for the patient have to wait for 3 to 4 months to load the processes. That 3 to 4 months is actually a trauma, psychological trauma for the patient, what I faced during my practice, because at that time patient don't have any teeth, and there are definitely the changes continuous in the bone happens. So in such cases, we are actually helpless what to do with the patients. So this actually thrust me to learn something new, what I can do for such patients, where I can give them the tooth immediately, where I can give the implant immediately, and where the patient can start chewing immediately rather than he or she has to wait for the 3 to 4 months. And sometimes there are the conditions, the conventional implantology, when the implants is failure also. So that also a trouble for the patient, because he has waited 3 to 4 months for placing the implant. Then after 4 months, the implant becomes failed. Then again it is a psychological trauma for the patient, and it's again a big trouble for the dentist, because again you have to wait to heal the bone and again place the implant, then again wait for the osseointegration. It will lead to nearly 6 to 7 months. These all problems actually thrust me to learn the cortical implants. So when I start learning these cortical implants, so first of all I book the OPGs of those patients to whom I reject. So there are the many OPGs, like the case 1 where we have a very less alveolar bone is there, where we cannot place the conventional implants, or the cases where the sinus pneumatization is too much and it is not possible for us to place the implant, especially in the maxillary posterior regions. And there are some cases which was highly infected at the time when the patient came to me and he told me that I want the teeth immediately, but I was not able to place that implant immediately over that reason, because the site was infected, and if I place the conventional implants over there, definitely it will gonna fail. There are some cases I remember where there was a buccal plate defect or the lingual plate defect. I was not able to place the implant over there, because when I open the flap and I open the defects in the buccal, the lingual plates, so I cannot place the implant in such areas. And the nerve distances are very less, especially in cases of the mandibular regions, because if there is a atrophic mandible and the nerve is very close to the alveolar bone, then again it is a restriction for us that we cannot place the implant, a conventional implant especially, that's a trouble for us. And if there is a severe atrophic maxilla or a severe atrophic mandible, so these are the conditions where it is almost impossible, or these are the rejected cases by me in the past years which I cannot treat it. So I put all those X-rays, I keep all that OPGs from the wardrobe, and then I start evaluating all those cases, what I can do now these cases. So to treat those cases, what I believe that I should learn some system where I can put the immediately implants and loading. Then I learned the cortical implants. So in the cortical implants, when I learned, then I came to know now the trends have changed. Now we don't need to go for invasive implantology, rather than we should go for the pinhole implantology. We don't need any sinus lift. We can treat the patient without sinus lift. We don't need to repositioning the nerve. We don't need to go for the rough implants, rather than we can go for a smooth surface implants. So if the implants are smooth surface, so the chances of infections are again less. We can immediately place the implant to the patient. So these are the some good points of the cortical implantology actually attract me to learn the cortical implants. So when I start my journey for the cortical implants, then you can understand like this, it's a journey from a 4 month to the 4 hours. Like when I started the implants, I have completed my case, one single tooth replacement case in a 4 month. But now what I am doing is treating the same patient in just 4 hours with the help of cortical implants, with even more success rates. So this is a trend where we have shifted myself from the conventional implants to the cortical implantology. So that's how nowadays I challenge everyone in my clinic when I promote myself, that you can get the same day implant and same day tooth, or you can get a fixed denture within a same day. I will extract your teeth on the same day, I will give you denture on the same day. This is only happened when I learned about the corticals. So the cortical bone is a bone basically which is above the alveolar bone, and it is a hard bone rather than a soft bone like alveolar, unlike alveolar. So it never resorbs. So we can place or we can engage our implant in the cortical bone rather than in the alveolar bone. So that gives immediate strength to load it immediately. In the conventional implants, we wait for the osseointegration, we are dependent on osseointegration, but nowadays we are not at all dependent on osseointegration if we have engaged our implants in the cortical bone. So we got the primary stability of implants through the cortical bone. So when we got the primary stability through the cortical bones, that means we can load it immediately. We are not dependent on osseointegration. With time, as osseointegration happens in the conventional implants, it will happen in the cortical implants as well. So it will give us the dual strength. The first, we give the osteofixation through the cortical bone, Then we did the osseointegration, like the bone did the osseointegration. This is the dual strength of the cortical implant, and that makes it osseofusion. So we osseo-fuse the cortical implant, not only the osseointegrate the cortical implants. So with the cortical implants, we can do so. And if we see the cases, something when we start doing the cortical implants, we don't have to give any cut, any incision. It is a kind of precision where we have to target our cortical bone. We have to target directly the cortical bone without any kind of incision. We don't have to give any incision. We directly use a single drill system. We use a single drill and do a pinhole osteotomy directly in the cortical bone, and we place the implant. So this what I have learned in the cortical implants. So now with this technique, I can say yes to each and every patient, rather than I say no, you don't have a alveolar bone, you have a sinus, you have a reduced bone. No, now these all are outdated now. If the patient came to me, I saw the bone. If the patient is diabetic, I don't matter, he is infected tooth, there is a less alveolar bone, atrophic maxilla, atrophic mandible, we can say yes to each and every patient. So when I have started the cases, I used to complete my full mouth cases in 72 hours. So earlier this time was 6 months, but after learning the cortical implants, this time reduced to the 3 days. So I placed the cortical implants in the patient. I extract the tooth of the patient immediately. Then I placed the implant in the patient's mouth, and immediately after that I took the impression and I prepared the denture as like a conventional complete mouth denture, and it's take the 3 days to let me complete or to give the tooth. The base is here is a metal framework. Through the metal framework, I did the rigid stability. So it is a case completion within 3 days or the 72 hours. But next was how I can improve myself with this 3 days. How I can convert these 3 days to 2 days. So for that, again, when the next patient, when I started and I extract the patient, extract the teeth from the patient mouth, and then I place the implant on the same day. Then there is another technique what I have learned, that is a sin crystallization. The sin crystallization through which is also in another way we can say the intraoral welding. So through the sin crystallization, we have attached all the implants together. So we have given the rigid stability of all the implants through the sin crystallization. So it omits the step of metal framework. So when the metal framework step is omitted, so that means we have sin crystallized it and we take the impression directly, and we can give shell denture to the patient right on the next day. So it reduced my time from 3 days to the 2 days when I upgraded myself with this sin crystallization. So this was another next level. Then again, how I can reduce my time from 3 days to 2 days to 2 days to 1 day. That means to reduce 1 day again, I have to update myself. So this time I added the digital dentistry in my clinic. So nowadays what I do, I place the implant, I did the sin crystallization, then I do the intraoral scanning of the patient, and after intraoral scanning I design the patient's tooth with the help of exocad, and afterwards I printed or milled the patient's tooth immediately on the same day, and on the same day I deliver the prosthesis to the patient. Now this in such a way, morning I have extract the patient's tooth, and in the evening I can give tooth to the patient. So this is the way how I upgraded myself from 3 days to the 1 day through the cortical implants. So this gave me immense strength and immense confidence now that I can treat all those patients to whom I rejected. So that gave me a confidence. So before doing that, I again give my challenge to myself that how can even reduce the timing for those patients to whom I have to do a segmental cases. Like if the patient came to me for 1 or 2 tooth replacement, can I give him in hours? So I prepared myself for that. So the patient came to me for the replacement of the two teeth. So I extract the tooth, I place the implant, and immediately I do the sin crystallization and into the intraoral scanning, and with the printed crown I replace that missing tooth or extracted tooth in just 4 hours. So that is how my journey is from the 4 months to the 4 hours. I started with the 4 months when I have completed the full mouth case. Now it is just a 4 hours when I have ended with the cortical implants and giving the prosthesis to the patient. So this all give me a confidence. Now I again get that all the OPGs to whom I rejected. So in those cases, which was like rejected due to the sinus pneumatization and all other complication, bony defects are there. So next my target was to do that, and actually I have placed all those cases. Now it is easy for me for the anterior segment, for the posterior segment to replace or to extract the tooth, place the implant and give the prosthesis to the patient. So in the cases where the first case, like I could say, in which there was in the case where there was a less alveolar bone, there was a patient came to me, the one side he has that side from a long, he is using that side for a long time, but another side he don't have a tooth for 6 to 7 years. That means this complete side is completely alveolar, loss is there. So earlier I reject that case, but now because I know the alveolar bone is of no use of mine, but he has the cortical bone. So I directly approach the cortical bone, I place the implant over there and give the prosthesis to the patient within a same day. So earlier the patient is, now the patient is very happy because earlier he was rejected and he was not able to chew, and he was also rejected by any other conventional implantologist. But I am happy to do that case because I am able to give the prosthesis to that patient. Another patient which was treated by me due to the sinus pneumatization, it was rejected by the other dentist, but because I treat those patients, I place the cortical implants and I then give the prosthesis to that patient. Then infected cases where it is almost contraindication for the conventional implants if there is a highly infection is there, but for conventional cortical implantology, as a cortical implantologist, I have to go beyond that infection and approach the cortical bone. So with that with that approach, I am able to do all those cases which are infected, and I immediately load those cases and give the prosthesis to those patients. Some of the cases like in which the upper molar, single molar missing and the bone is not at all over there, it was completely reduced, only 1 to 2 mm bone is there. That patient was missing, that tooth was missing, and patient was not at all given to the tooth by anyone, because it is not possible without any surgical intervention. The surgical intervention is he has to go for the sinus lift, direct or indirect, and then the bone grafting. Then he is able to place the implant over there. Then only dentist can place the implant over there. And after placement of the implant, he has to wait the 6 months so that implant can be stable over there. But the patient came to me that he don't want to go for the sinus lift surgery. Now my target is now cortical implant again, so I don't care about whether the alveolar bone is less or high. So I directly approach with the conventional cortical implants and immediately place the cortical implant and give the tooth to the patient. So with that, I have treated many patients with the bony defects, with the sinus pneumatization, or with the all those cases which need the immediate extraction and immediate placement. So I did all those cases, and some of the cases where the nerve is very close, again we can go for the lingual bypass or the lingual cortical implants. Rather than do the nerve repositioning, we can go with the lingual cortical implants. So with that, we can give prosthesis to the patients. So this is how now I am able to treat all those patients which was rejected earlier with the help of the cortical implants. Now I can say yes to every patient. Yes, you can go with that implants.
Thank you, doctor.
Thank you. Thank you so much.
Doctor, is there any advice you would like to give people who want to start a cortical implantology?
Yes. Everyone who is doing implantology, the first thing I would like to say that continued education is a must part of your life. If you want to be high in your practice, whether it is implant practice or any other dental practices there, the first thing is the continued education. You should never think that you have learned the implant, that's enough. No. Every day you should learn something new. Second thing, the patient education is a must. Whenever you counsel the patient, always educate the patient properly that what is going to be happen, how it is going to be happen now. The third thing, you should add the digital platform in your daily routine practice. As we know that the life and the science is changing every day. When everything is changing, that means you have to upgrade yourself in your practice. So earlier, whatever we are doing, but now with the help of the digitalization, we can give the more accuracy and the precision to the patient. The fourth and the fifth pillars are the networking and the marketing strategies. You should go with that also nowadays, so that you can improve your practice as well. And as far as if we concern about the how we can manage the complications with the implants, it is always better to evaluate the case properly before taking the case. And it is what my perception is. We always talk about how we can manage the complications, but my perspective is you should always choose that way, or we should always leave that way which actually create the complications. When I was in a conventional implantology, I learned that conventional implantology itself creates some of the complications. We have to do some complicated procedures to do that conventional implants, but if we can bypass those procedures through the change in the technique, that is much better. We can prevent the complications. Rather than managing complications, we can prevent the complications by improving ourselves of the continuing education and by doing the cortical implant.
Thank you, Doctor.